Well, I think it means that if we figure out what's explaining the 15% gap, then we can really find a very little difference in the next 10 years, right? But in terms of the 15% gap, there is, we thought perhaps it was the drugs that the patients were taking, and were there certain drugs that they were more wary of or the doctors were more wary of, and that was the reason. At least statistically, that did not seem to hold up in our study. And so we're going to be looking at other factors to see what explains that gap. And I think that is going to be an ongoing question in our field. Kind of to restate it another way, like we've vetted certain drugs, so are the newer drugs coming out still need to be vetted, and I do think that is somewhat true. For the most part, a lot of the decisions around what medications patients are taking when they're breastfeeding are the same for most women, the same decisions we make about what we put them on as young women as we feel that they're good drugs or safer drug options for pregnancy. And so I don't see overall, and a lot of the stuff presented at this meeting by the International Pregnancy Registries is that, our prescription practices are veering more and more towards drugs that are well known as safer options in pregnancy, and those also happen to be the ones that are safer options for breastfeeding that we know about. But you're right, when a woman is on a drug with a less clear research, pedigree, if you will, about both pregnancy and breastfeeding, we do counsel slightly differently. But I do think the messages from the research is getting out that overall what we do know is how much benefit there is to breastfeeding. And so we shouldn't take what we don't know about a drug and weigh that too heavily against what we do know about breastfeeding's benefits.